I have no conflicts of interest regarding this presentation or any of the materials therein. What is the point of using sutures to repair lacerations? Well, simply it's to facilitate tissue repair, hopefully in a cosmetically pleasing fashion, and it is dependent upon a number of things, including the type of wound, the cleanliness of the wound, and that will dictate what type of sutures one uses and what type of closures one uses. And these are all things that we'll be talking about today. In order to understand the role of suturing in laceration repair, we have to have a basic understanding of what the body's natural response to injury is. And the first of those responses is hemostasis and inflammation. The body is very good at stopping bleeding. When there is obvious vessel laceration, arterial or venous, that's a little bit more difficult to accomplish on its own. But in general, the body will bring in factors that stop the bleeding, vasoconstriction, activate the clotting cascade, and then inflammatory cells will come in to clean and prepare the wound for healing. Once the wound is hemostatic and has been cleaned by the inflammatory mechanism, then wound repair begins with fibroplasia and angiogenesis as described here. The final phase of tissue response to injury is wound maturation. And as you can see by the timetable here, there are varying degrees of strength in the wound. In general, for the acute phase of maturation, usually within 2 weeks, the wound is sufficiently strong, particularly after suturing, to maintain integrity. And at that point, there's not much one can do that is going to disrupt the wound in general. But you can see that the actual completion and remodeling of the scar, the wound, will continue for the course of a year and even longer. This is a graphic of what we've just discussed, the phases of wound healing. And again, you can see that the complete maturation process goes up to and even past a year. But what I want you to take home with this is that the acute phase of healing, in that acute process, the wound is going to be fairly sound. And this is important when talking about when are you going to remove sutures. Generally within 2 weeks, quicker in some instances, a little bit later in others, but in general, around the 2-week mark, you can allow your patient to get back to their general regular activities. The wound is going to be strong enough to withhold any of general day-to-day activities without becoming separated. Now, that's not to say you'll keep sutures in that long. In some cases you will, but most times you're going to remove sutures within the first week, sometimes within the first 3 or 4 days. But you will still ask your patient to have limited activities for those first couple of weeks, just to not apply any undue stress on the wound that you've just closed. So in providing wound closure, what are the principles that we want to be mindful of? Well, the first thing is you don't want to trap in infectious material, so you want to minimize bacterial contamination. So the best way to do that is irrigate with just saline, ringers, anything like that. And we'll talk about that in the discussion regarding preparation of the wound. You want to remove any foreign bodies. If there's splinters, pieces of glass, you need to make sure those are removed, and also any devitalized tissue, which would require some form of debridement, whether it's going to be sharp dissection, or wet to dry dressings. Obviously, you want to make sure that the wound is hemostatic. You don't want to close it if it's actively bleeding. You want to make sure that the bleeding has stopped, because blood is a very good medium for the growth of bacteria. And of utmost importance is handling the tissue gently. Remember, it's already been injured, and you don't want to add to the injury. So what you would want to do is, when you're doing your closures, you want to use fine-tooth forceps, and generally Adsons or small pickup with teeth are going to be the ones that you want to use, because they will grab the tissue with less force and they do not crush tissue, as will happen when you use smooth forceps. Now, there are times when you will use smooth forceps, but that's generally going to be on internal organs that are being sutured, not simple lacerations. So in general, you want to use some form of fine-tooth instrument to handle the tissue, because you don't have to use as much pressure to do so. And an old adage is approximate, don't strangulate. When you're closing the wound, do just that. You want to close it. You don't want to have the suture so tight that it results in ischemia. And remember, in the process of suturing, there will be some inflammatory response. There's going to be some swelling, so there's going to be some tension placed on that suture line for the first few days to a week or so. So be sure that you have the skin well approximated, no gaps in it, but you don't want to strangulate it. Before one determines to suture a wound, one must be cognizant of the characteristics of the wound. You have to evaluate the wound. So some things to consider. Number one is location. The face is very important, because obviously there's going to be cosmetic issues there. The hands, the perineum, tend to be a little bit more complicated for structural reasons in closing, so you have to be cognizant of that as well. Less complicated are lacerations of the scalp, the trunk, the arms, the legs. These are generally pretty easily closed without too much difficulty. You have to consider the size of the wound. How long is it? How deep is it? Does it go into the fascial planes? Does it go deeper into the muscle planes? Does it potentially involve nerves, blood vessels, muscles? Is there tendon injury that needs to be addressed? So that if the wound is very deep and you are uncertain as to the status of these deeper tissues, it's best to leave it alone and let someone who's got a little bit more experience to close those type of wounds. Consider the mechanism of injury. How did the wound occur? If it's a puncture wound, depending on how deep these are, and you may not be able to determine that in your initial evaluation, but if you have a nail that goes deep into the foot, well, it could involve fascial planes, ligaments, bones, and you have to remember that there's a potential that there's a great deal of contamination. So puncture wounds, knife wounds, nail wounds, things of that nature, oftentimes the best thing to do is clean them and then leave them open to avoid closing in infection. And again, puncture wounds generally don't have very smooth edges that are amenable to suturing. Lacerations from sharp trauma. These are generally pretty easy. You can generally see the depth of the wound. If it's full skin thickness, then it's easy to clean it, and then you can suture or staple or tape the edges together, or dermabond, any of these things. But again, take into consideration the depth and the length of the wound and where it is. Lacerations from blunt trauma. These are often going to result in bruising, damage to the wound edges, a lot of avulsions where the wound thickness and the skin depth may vary, and these are often more difficult to close, and often will require debridement around the edges where there has been potential vascular damage and injury. So again, some of these may be best left open initially. Another consideration is how long ago did the injury occur. In general, any wound that has been exposed for greater than 8 hours, regardless of what the mechanism of injury was, is at a greater risk for infection, and these are generally going to be best left left open. What's the likelihood of contamination? Again, if the wound's more than 8 hours, if it's grossly contaminated like an animal bite, a human bite, a farming injury, um, something of that nature, then again you should consider leaving those open, cleaning them, and leaving them open, and perhaps closing them later or letting them close on their own. And then there's the patient-dependent factors. How old is the person? What is the nutritional status? Do they have diabetes? Are there other comorbidities? Um, is there going to be some issues with scarring and other risks for infections? And you need to consider all these before determining whether to close and how to close the injury. With all that being said, the most likely injury you're going to encounter that you're going to want to close or feel comfortable closing is just going to be the simple laceration. But there are occasions where you might want to do a delayed closure. And so I want to give you a little information about what are the categories of wound closure, and we'll list those here. The first is closure by primary intent. That's when you close the injury right away. You're going to clean it, and then you're going to suture it closed. You're going to approximate, not strangulate. And again, most patients with a simple laceration within 8 hours of the injury can be closed by primary attempt. The face is actually a little bit more forgiving. It's so vascular that you can actually do a primary closure as late as 24 hours after the injury. And that's important because you're going to get a better cosmetic effect when you close by primary intent. So bear in mind that in general, 8 hours is the time limit for simple lacerations. However, on the face, you can go up to 24 hours as long as the injury is simple and you do a thorough cleansing. The next category of wound closure is closure by secondary intent. This is actually when you allow the wound to close on its own. You may see this often with surgical incisions that dehiss. You've seen in the hospitals wet to dry dressings. Well, that's what is going on there. We're allowing for secondary intent closure. By doing the dressing changes, you're debriding the wound each dressing change as you pull out the contaminants with the dressing change, and granulation tissue is forming, and that wound is closing from the bottom up. And you've all seen with dressing changes, the wounds gradually get less deep and become approximated. And oftentimes the closure is fairly cosmetic. Times that you want to do this are again when you have a known contamination. There's a vols of injuries that don't really lend themselves well to primary closure, such as finger amputations or partial thickness avulsions where you don't have the full thickness of the skin involved. Those are often best closed by secondary intent. And the final category is closure by tertiary intent, also known as delayed primary closure. In this circumstance, you may be doing dressing changes, wet to dry dressing changes, and then once you get a good bed of granulation, you're sure that the wound is free of infection, then you can go back and actually suture the wound closed. Again, this might be something that you would do for an injury that's greater than 8 hours, but that you still want to have a good cosmetic result, because again, secondary intent closure, although it's acceptable, it's not going to be as cosmetically pleasing as a primary closure or a delayed primary closure. So let's talk about how we prepare the wound and the stare technique that's going to be involved with closing the wound. First thing is you have to be able to see the wound margin. So if it's in an area where there's a lot of hair, then you need to remove the hair. Don't use a razor, use a clipper, use scissors. You don't have to have the hair completely gone. You just have to have it to where you can delineate the edges of the wound. Do not shave the eyebrows. If it's an eyebrow laceration, again, you can clip with some small scissors, but don't shave, particularly as people get older, the eyebrows tend to not grow back as well. One caveat is if you have a scalp laceration that's in the scalp under the hair, and if you're not concerned about, cosmesis because, again, it's under the hair, you don't need to remove the hair there. Just close the wound with staples. You'll still clean it. You'll anesthetize it. Just get a skin stapler and close with that is an easier closure. You just have to make sure that you don't have hair trapped between the skin edges, so you just tweeze it out if it is. But that's better than having a big patch of cut hair on your head because it doesn't matter. So the next consideration is anesthetic. Before you clean the wound, and certainly before you suture the wound, you want to make sure that the patient is adequately anesthetized. And generally, for a simple laceration, you're just going to use a local block. However, occasionally you might want to do a nerve block. For example, if you're going to be doing something on the fingers, you can actually do a digital nerve block. Those are pretty easy to learn, but again, for the most part, you're just going to do a regional local block. So when doing so, you're gonna clean the site. Alcohol is fine, the injection site I'm talking about. And then 1% lidocaine is generally the most commonly used. You'll see the recommendations as listed here: 3 milligram per kilogram body weight. You're really not going to give them too much anesthetic as long as you're in the periphery. So just keep that in mind, but don't be too worried about it. It's actually hard to get to that level for a simple laceration. With the 1% lidocaine, you're gonna get a pretty immediate effect, and it's gonna last anywhere from 30 to 60 minutes. You also will see that you have a 0.5% lidocaine. That's actually pretty good for pediatric patients because it tends to sting less. And then you'll see 2% lidocaine, which again, it's pretty commonly in the clinics, and you can use that, but it's really overdue. You don't need that high percentage of lidocaine, but if that's all you have, then use it. Lidocaine with epinephrine. So the epinephrine in the lidocaine is a vasoconstrictor, so you do have to be sure when you inject that you are not injecting intravascularly. So when you place your needle, before you inject, aspirate, make sure you haven't gotten into a vein. And what the epinephrine does, it serves as a vasoconstrictor, so it does two things. It actually will help decrease the bleeding in the wound, which can be beneficial, and it also prolongs the anesthetic effect, so that if you think your suturing is going to be a little bit more complicated, it's going to take longer than 30 to 60 minutes, then you should consider using epinephrine. The caveat to that is finger, nose, penis, toes. Do not use lidocaine with epinephrine in these areas because of the vasoconstrictive effect. You can actually get necrosis of the tip of the nose or the fingers or the penis and toes. So always remember, fingers, nose, penis, toes, no epinephrine. Lidocaine does burn, but you can really minimize that significantly by using a very small gauge needle and just slowly infiltrating. And then once you get the initial infiltration done, then you can go faster, and you can even change to a larger needle if you prefer. So once you've gotten the wound anesthetized, then it's time to start cleaning the wound. And this is where you're going to be using the antiseptic medications such as betadine, chlorhexidine, any of those things. And that's going to be important when you're placing your sutures, that you're not bringing skin bacteria into the wound. Be careful though; these solutions are toxic to the subcutaneous tissue, so that you want to minimize exposure of that. And of course, you're gonna rinse all that out after you've anesthetized. The wound irrigation is very important. Before you start closing, you're gonna irrigate to get any foreign debris out, to irrigate bacteria out. And at this time, if you see devitalized tissue, then you're gonna use some tweezers and some scissors and just cut back that devitalized tissue before you proceed with suturing. So now you've got the wound anesthetized, you've got it cleaned, you've got the antiseptic solution, so you're ready now to begin suturing. So this is where you really have to be cognizant of your sterile technique. Any break in the sterile technique is going to introduce bacteria into the surgical site, and that can result in wound infection and wound breakdown. So you have to be cognizant of that. It's not, you're not in the operating room, you're not dealing with deep structures, so it's not as bad as it could be as far as contamination, but you still need to be aware of it and make sure that you're doing everything to prevent contamination. So you have to be able to do the things that you know how to do generally, and that is put on sterile gloves in a sterile manner. Be sure that you have a drape, and usually you're going to want a fenestrated drape to expose the wound, but you also want a plain drape that will cover any area that could be potential sites of contamination. When you're suturing, it's very common for the end of your suture to drop, and if it drops, you want it falling on your sterile field, and by drop I mean the end of the suture, so that when you're dragging it across the surface, it is going across a sterile field. Be sure that your instruments are laid out on a sterile drape, and that there's minimal risk of contaminating when you're picking one up and bringing it to the surgical field. Make sure that you have the appropriate suturing materials, and generally you can have prepackaged minor surgical sets or suture sets, which will include all of these things. You'll have a tray of instruments, which generally will include a needle driver, a fine-tooth forceps, a hemostat, and a suture scissor. Generally, you'll have some gauze. You also need to make sure that you have drapes, both full and fenestrated, as well as sterile gloves. Be sure you have these materials, whether you do them as pill packs or you do have the suture sets. Make sure you have this in your office. And it's also a good idea to have one or two of these at home, because once people realize you know how to suture, they're going to be bringing kids to your front door at 9 o'clock at night to stitch up a laceration on the forehead or something like that. So it's a good idea to have these materials available to you. And again, most of these can be bought as prepackaged sets. The next thing to consider is what are your suture materials? What kind of suture are you going to use? What kind of needle do you use? So I want to go over some of these issues with you real quickly. So there are basically two types of needles: a taper needle and a cutting needle. The taper needles are smooth needles. They're just regular pointed needles at the end, and they are designed to go through tissue that's not dense. So subcutaneous tissue, fatty tissue, bowel, blood vessels. In general, for the type of suturing you're going to be doing, you will not use this needle, except for if you have a deep skin laceration that goes into the subdermis, where there's a pretty good layer of fatty material. You would maybe want to reapproximate this tissue before you close the skin, and in that case you would use a taper needle. In general, you're going to be using cutting needles, and that's just what it says. The needle has a blade built into the tip of it, and this is designed particularly for skin closure. When you look at needles, you're going to see different letters and designations, and they can vary by the manufacturer of the needle, but these are some of the most common ones. You'll see CT, that's a circle taper needle. So again, that's not a needle that you want to use on the skin, but if you're going to be closing subcutaneous tissue to reapproximate it prior to closure of the skin, this would be the needle that you'd use. P stands for plastic, PS, plastic skin, FS for skin. These are the needles that you're going to be using for skin closure, and these are generally, these are cutting needles. And then SH, as you see there, stands for small half. That's actually also a taper needle, and that would actually be a needle that you would most likely use in closing subcutaneous tissue, because it's a small needle. You can get down into the wound with it and make the full turn without having difficulty of a large needle. So the number of the suture designates how big the needle is and how big the suture is. So example, you have 5/0 suture gives you the needle size as well as the suture size. And remember, the higher the number suture, 5/0 is smaller in diameter than the lower number. So a 1/0 suture is thicker, and the needle is thicker than a 5/0 suture. So again, we mentioned this, the needle choice is going to be dependent upon what tissue you're closing. If you're going to be closing the subcutaneous tissue because you have a deep skin laceration, then you want to do that closure with probably an SH needle, which is a taper needle. And then you're going to want to use a cutting needle to close the skin. Now, when we talk about cutting needles, there's two types. There's a regular standard cutting needle, and there's a reverse cutting needle, and we'll talk about those. So you can see the needle on the left is a taper needle. And if you look at the cross section, you can see it's just got a little point and it's perfectly round. And again, that's going to be used for tissue that's smooth and friable, like fatty tissue, and again, blood vessels, muscles, things of that nature. The conventional cutting needle, or the standing cutting needle, you can see has a blade that is at the tip, and it cuts toward the inner arch of the circle, so that when you're making your needle insertion, you're actually cutting the skin. And then the reverse cutting needle, the cutting blade is on the outer arch of the circle. This is important because when you have very thin tissue, like let's say an eyelid or tissue that's weak, you want to use the reverse cutting needle because you want the tension of the suture when you tie it to not be in the area where the needle made the cut. So in the conventional standard cutting needle, if you use that one, when you tie the suture, your suture tension is in the cut that was made, whereas on the reverse cutting needle, the tension is away from where the cut was made, so there's less likely to have pull through. And that's also important in areas that there's a lot of tension. In general, it's probably always a good idea to use a reverse cutting needle. So I would tend to tell you to have that as your go-to needle. But if you have a conventional cutting needle, as long as the skin is thick and it's durable, then you'll be fine with that. And again, approximate, don't strangulate. If you tie your suture too tightly, particularly with the post-operative edema, you may get some cutting into and pull through of that suture if you use a conventional cutting needle. This is just a diagram of a needle anatomy, just so that you have an idea of what you're looking at. Of course, you see the point. That is the portion that's going to go into the skin. You don't ever want to grab the point of the needle with your needle driver. That is the most fragile part of the needle, and if you grab it either when handling or when you're pulling the suture through, then you will bend that point, dull that point, or even crush the cutting edge so that it doesn't cut anymore. So always grab the needle with your needle driver in the body of the needle. For more control, you're gonna grasp your needle closer to the point, not on the point, particularly if you have to have small areas that you're suturing, and if you need to take bigger bites, and you're going to go more toward the swagged end of the needle. You have less control there, but you get more traveling distance. The swagged end is where the needle is attached to the suture. There actually are what are called Mayo needles, which is just like a regular curved needle, but it looks like a sewing needle. You actually thread it. Very rarely will you use that. Most needles now are packaged and swagged. The swag can be what's called a swedged on, which does not come off. It's designed to stay intact until you cut it. And then you have a pop-off swedge. And these are sutures where if you're doing interrupted sutures, you actually pop the needle off and then tie the suture. Most of the times, you're going to have a swedged on needle which will not pop off, and that's really what you want because you're often going to be doing continuous sewing. But even without, you can always cut the suture and then use that same suture with the remaining length for your next stitch. So these again are just the anatomy of the needle that you can look over. So next you need to determine what type of suture material you're going to use, and there's two types. You have absorbable and non-absorbable. Absorbable suture you're going to want to use for any subcutaneous suturing, again when you have a deep skin lesion that you're going to close the fat, or if you do a subcuticular suture, and we'll talk about that in your skills lab. But that's basically a suture that goes into the dermis, but it's underneath the surface, and so you don't in general take those sutures out. So any sutures you're not going to take out, you want to use absorbable. Examples are monocryl, PDS, Vicryl, which is a braided suture, and then catgut and chromate. Non-absorbable sutures are for sutures that you're going to remove. So these are generally going to be for skin and slow healing tissues. And examples of non-absorbable sutures are nylon, Ethylon is a brand of that, Prolene, and then you have the natural sutures which are non-absorbable, which are silk, cotton, and steel. You'll never use a steel suture unless you're going to close a sternum for open heart surgery. But in general, the most likely are going to be probably Prolene or nylon for your skin closure. Now you can use absorbable sutures for skin closures as long as it's going to be a suture that's going to be removed within a couple of weeks because it does lose its tensile strength over time. But if you want to use a monocryl or a PDS on the skin, you can do so, and you'll just you just cut it out as usual. But don't use a non-absorbable suture in areas that you can't remove it if you need to. So let's talk about what suture material you might want to use depending upon where you're suturing, where the site of the laceration is. Again, if you're going to use a subcutaneous stitch or a subcuticular stitch, you're going to want to use an absorbable suture. Vicryl is really nice to use as a subcutaneous suture, but remember that vicryl is braided, so it's a number of strands braided together, just like when you braid your hair. Because of that, there's little nooks and crannies where bacteria can reside, so that if you're worried about infection, you don't want to use that one. Monocryl and PDS are good for subcutaneous tissue. They're monofilament, so they don't have the braidings, and you can use these also for subcuticular suturing. Now again, subcuticular suturing does not have to be removed, but it can be removed. And I actually do most of my subcuticular sutures where I do remove them, but it's easy. You just pull it through when they come in for their post-op visit, and we'll talk about how to do that when we do your skills lab, if that's a technique you'd like to learn. Subcuticular sutures are often good for children because you don't have to have them come back in and take the suture out, which can be somewhat traumatic sometimes. So skin closure, what are you going to use where? On the face, you're going to want to use a lower caliber suture, so a 4.0, a 5.0, 6.0, 7.0 monofilament non-absorbable suture such as nylon would be used. Depending on how good your vision is, you may or may not need loops. Loops are just magnifiers that help you to see these sutures a little bit more clearly. But again, depending on your vision. Other areas and again on the face, remember the face is generally, there's some areas that are quite thin, so if you're in a thin area, make sure that you're using a reverse cutting needle. Other low skin tension areas that you want to have a good cosmetic result, you may want to use a 4.0, 5.0 nylon. Again, depending on your vision, you may need loops. If there are higher tension areas like skin over an elbow or a joint, knee, something of that nature, over the jaw, you might want a higher gauge suture like a 4.0 nylon. Foot, 3.0, 4.0 nylon Prolene. Chest, abdomen, extremities, 3.0, 4.0, any of that's fine. Whenever you're getting into the brow, the hand, the penis, the scalp, hopefully you won't have to worry too much with those, but you'll use a non-absorbable suture. 5.0, 6.0 is perfect. Nose, lip, ear, those are going to have to be really small sutures, so 6.0 or 7.0. And again, depending upon how your vision is, you might benefit by having some magnification. So now you know your needle type that you're going to use, you know the suture type you're going to use, you know the size of the suture you're going to use, whether you're using a cutting needle, reverse cutting needle, taper needle. So what type of stitch are you going to use? The most common and easiest stitch to use is just a simple interrupted, and that's where these are for wounds that approximate easily. They're not under a lot of tension, and you just close them at intervals. Oftentimes recommend you start in the middle of the wound so that you have an even closure, and then just centimeter to half a centimeter apart. Throw stitches in time interrupted until the wound is closed. That's very easy. Again, that's the most common type of suture that you're going to use. If you have a wound under tension where the edges don't approximate very readily, or if it's over a bony prominence, then you might consider doing a vertical mattress. This is what you've heard of the far, far, near, near. And so what you'll do, and again, we'll go over this in the suture lab, you're going to take stitches perhaps a centimeter from the edge, and you're going to go rather deep, actually to the base of the wound, and come out equidistant on the other side. And then on that same side, you're going to go near to the edge, just through the full thickness of the dermis, and then you're going to come out on the other side, and you're going to tie it on that side. And what that does, it everts the skin, allows for double strength on each side, so that when the skin is under tension, it's not actually pulling at the suture line, but deeper than that. And that's a good stitch to learn for those type circumstances. We'll talk about the horizontal mattress. That's a similar suture. It's the orientation is a little bit different. The first two stitches are on the same side, and then you go across to the other side. It's not as good as for cosmesis, but it is good for wounds that are under closure or under tension, so that you have a good closure that's going to be strong for the duration of the time you need to leave the sutures in. A figure of eight suture is basically you're making an X, and that's designed to stop bleeding. Often you're not going to use this for simple lacerations, but occasionally you'll have a little skin bleeder that you can't stop, and you should know how to do that suture. And we'll talk about that as well. The baseball stitch, that's basically a continuous simple suture, and that's something that's easy to perform. The subcuticular suture is what we talked about a little bit ago. You're going to be taking the needle into the dermis, but beneath the surface where you actually don't see any of the stitching. And then you have a running mattress suture and a running locking suture. Neither of these are you likely to use, but we'll talk about it if you're interested during the skills lab. So of utmost importance is the knot tying. Once you have your suture in place, you have to be able to tie it and make sure it stays in place. And so we'll talk about this as well in the skills lab. There are 3 different types of knot tying. There's a 2-handed tie, and you should know how to do that both right hand and left hand dominant. There's a 1-handed tie, and again, you should be able to do it with the right and left hand. And then the instrument tie. And honestly, for the type of suturing that you're most likely to be doing, these simple lacerations, the instrument tie is probably going to be your go-to tie. And we'll spend some time particularly teaching you how to do that and refining that technique, although you should learn, and we'll help you with the other 2 tying techniques as well. Dressing the wound is the final portion of the suturing technique. You've got the wound closed, you've got it cleaned, so now you want to dress, and the dressing is strictly to protect the wound from any gross contamination over the course of healing, and to also absorb any blood or oozing from the wound. Because remember, there's a significant inflammatory process. There's some swelling afterwards, and it's not uncommon to get a little bleeding, little serous drainage from the wound for the first few days. Sometimes you're going to want to put a pressure dressing on. Those of you who have done the Implanon, you're familiar with that, of putting pressure over the site to prevent swelling and hematomas. Wounds that stay covered for over 48 hours are more likely to become infected, so that when you send your patient home, what I usually do is tell them to leave the dressing on for up to 12 hours, and then either take it off and leave it off, or take it off and change it if there's still some drainage on it. But certainly at 48 hours, they need to remove the dressing. If a dressing becomes soaked through, then it needs to be changed immediately. So make sure when you send your patients home that they have or can get the supplies to change the dressings as appropriate. And remember, wound dressings are not sterile. This is not a sterile technique. You've done all the sterile stuff already. Now you're just covering the wound that's already been closed. So it needs to be clean, but it does not have to be sterile. So you are the patient. You don't have to put on sterile gloves and drape and all that kind of stuff. You just cover the wound in a clean manner. Use the amount of dressing that you need to use to absorb any serous drainage or bleeding. And again, change the dressings when they're wet, or certainly within 48 hours. Usually, again, like I said, I have my patients take the dressing off the next day and leave it off, and that's fine. Once the wound is closed, it really takes only about 3 days for the epithelial layer to close over the wound, so that they're at that point protected from any type of immersion. In the first 24 to 48 hours, it's a good idea to tell the patient it's okay to bathe and shower, but don't stay immersed for long periods of time, and just kind of pat clean and pat dry. But it's fine. They can actually get in the bathtub and things like that. They just don't want to spend a prolonged period of time soaking underwater for the first couple of days. Another consideration is tetanus prophylaxis. When does one require a tetanus shot after an injury? And here's the answer. In patients who have a clean, simple laceration, if they have had a tetanus booster or their primary immunization within the past 10 years, then they're good. If the wound's a dirty wound, if it's contaminated with saliva, dirt, anything of that nature, anything that makes it basically a dirty wound when they come in, then if they've had their primary immunization or booster within the past 5 years, they're good. But if it's been longer than 5 years, then they need to receive another shot. If the patient has never had their primary immunization, or if they don't know, then they should be given the tetanus immune globulin, and then should also be getting the tetanus diphtheria toxoid as well, and then be sure they complete the immunization protocol. So that's the guidelines for tetanus prophylaxis in the face of injuries. When do you take the sutures out? So that depends upon the amount of tension the wound is under, and you want to balance the strength of the wound, make sure the sutures are in there long enough to assure that the wound doesn't break open, and balance that with scarring. The longer you leave the sutures in, the more scarring is going to be pronounced. So you'll see guidelines here of when, in general, to remove sutures. Now remember, these are generalities. You'll have to individualize this for your patients. The face, as I said, is very forgiving. It's very vascular. It heals very quickly. 3 to 5 days is good for the sutures to come out if it's in areas that are not under tension, in areas that would have a significant impact if cosmesis was not acceptable. So you want to remove those in 3 to 5 days and put steri strips on them, and have the patient leave the steri strips on for a total of 7 days, if possible. On the scalp and the trunk, those are thicker tissues, so you're going to want to leave those sutures in 7 to 10 days, 10 days to 14 days, really, if there's a lot of, or you suspect a lot of tension in the area. Again, if it's not a worry about cosmesis, then you want to err toward leaving the sutures in a little bit longer. But generally, 7 to 10 days is fine. On the arms or legs, again, those are mobile organs, so you may want to leave those in 10 to 14 days. And if you're going to have any sutures over joints where there is a great deal of tension, then you should leave those in for a couple of weeks. Well, thank you for your attention to this presentation, and we will be talking more in the skills section and doing some actual suturing and talk more about technique. The remainder of the slides are just a few self-assessment questions. See how well you come away with the information that's been presented to this point, and we will see you all in the skills lab.